Thanks, Andrew. I'd like to thank the organisers and Delca for the privilege of speaking today. These are my disclosures. If I was giving this talk 10 years ago, we might as well go home. Survival at 5 years with stage 4 colorectal cancer was about 3%. And at that time, we had 5-FU and folinic acid, and we spent the whole of the 90s debating, should we give it as bolus or should we give it as infusion? Should we give low-dose folinic acid, high-dose folinic acid? And overall, a very small number of patients were offered liver resection. Now, at the same time, in specialized centers, and these are data from MD Anderson and Mayo Clinic, published by Scott Coppetts in JCO 3 years ago, for those patients that could make it to these two centers in stage 4, overall survival has been improving significantly. From the cohort at the bottom, 1990 to 91 in dark blue, to the white line at the top, a significant improvement. And these are for all patients in stage 4, not just those with resectable liver metastases. So something like 30% of patients in stage 4 at these two centers were getting out to 5 years. Now, in that time, we'd gone from the 1990s with 5-FU folinic acid as the treatment for inoperable disease, the introduction of irinotecan, oxaliplatin, and then the arrival of the wonder mAbs, cetuximab, bevacizumab, panitumumab, and more recently aflibercept and regorafenib after the turn of the century. And has that had an impact? Well, it has. If you look at, on the left-hand side, those patients in the blue curve who have a liver resection, they're looking now at 40-50% 5-year survival. But look at the orange curve. These are the patients who are receiving medical management only. And they're now getting out to 1 in 5 surviving out at 5 years. At the same time, on the right-hand side, the use of liver resection in the early 90s at both MD Anderson and Mayo Clinic, very low numbers. But again, in the late 90s, a sudden surge of interest, increased use of liver resection, and therefore more patients who are resectable living longer. Now, that's all very well if you can afford to make it to MD Anderson or Mayo Clinic. What happens in the real world of the NHS in this country? Now, we published these data a couple of years ago in the BJS. This is Eva Morris's work when Eva was working for Northern Yorkshire Cancer Registry, now works at the University of Leeds. And Eva has been tasked by the National Cancer Intelligence Network in England of tracking every patient with colorectal cancer through the system since 1996. She knows who they are, she has their NHS registration number, she knows where they live, she knows stage at diagnosis, she knows who's operated on them, she has the GMC license number of every consultant surgeon involved in their care, and she knows the OPCS code of every operation they've done to them, and she has the overall outcome on now nearly 450,000 patients. Now, in this particular group of patients, we looked at 114,000 who were diagnosed between 1998 and 2004, 50%. Only half were alive 5 years later of all those patients. And in stage 3, it was barely 40%. Stage 4, like the earlier data I showed you, 5%. But for the 3,000, if it will actually advance for me, and it's not, 3,116 in stage 4 resected with liver metastases, their survival is the same as stage 3. Now, what that tells you is that if a metastasis is resectable, it doesn't matter where it is, be it lymph node or liver, the outcome is the same. And all that really shows is we've got staging wrong. Stage 3 should be resectable metastases, stage 4 should be those who are unresectable. But what it does show you is that those patients who are resectable with liver-limited disease have a reasonably good prospect of survival. So our definition of resectability has now changed from that which was 10 or 12 years ago of up to 3 unilobar metachronously detected metastases to that which you can take away, leaving behind sufficient volume of viable liver. So the question is, how much should that be? Well, probably 25 to 30%. What's your resection margin? Well, I'll accept a millimetre on intention to treat. It's the preservation of functional liver anatomy. And if that is the case, 20% of patients are now resectable with curative intent at presentation. What about ablation? Well, this was a trial we agonized over for 12 years from conception to publication. The ERTC 40004, the CLOCK study. Patients went into this study if they had unresectable but liver-limited disease that was ablatable. And they were randomized to chemotherapy alone or chemotherapy plus ablation, be it percutaneous, laparoscopic, or open. The problem was we wanted 400 patients in the study. The primary endpoint was looking at 30-month overall survival. We launched it after ablation became widely available, and patients said, well, why should I go in the trial? And the trial collapsed into a randomized phase 2, and the problem was that both groups of patients, chemo alone and those getting chemo plus ablation, all lived out to 30 months. We only randomized 105 patients. When we published the data last year, there is a trend, and no more than a trend, to better survival out at 5 and 6 years in the very small numbers of patients who had ablation therapy. Now, this will never be significant. The study was never powered to show that, but it is the only randomized trial that we've ever done and ever will do in this area. Does ablation have a role? Well, these are data from the European Liver Met Resection Registry, Liver Met Survey. In the green are the 10-year survival figures for patients who are resectable and had liver resection. In red are those patients who required a combination of resection and ablation to clear the liver. Not as good as the green, but roughly 20% of those patients are alive at 10 years. So probably there is a place for combination resection and ablation if patients cannot be cured or cleared out with resection alone. What about chemotherapy? On the left-hand side of this picture, of this slide, is a patient who looks clearly inoperable. And this went to the local colorectal MDT outside Glasgow. You'd say, oh my God, this is incurable. Well, on the right-hand side is the patient after 6 cycles of 5-FU flinic acid oxaliplatin. And even a medical oncologist could resect that. So those patients have now got the chance of being potentially cured if they have sufficient response. So we have a paradigm that looks like this now. At the top of the slide, liver metastases, liver limited, 20%, 1 in 5 resectable up front. The other 80% will go forward to systemic chemotherapy or with or without a biological therapy, of whom some will convert and move across to the right-hand side with a chance of cure. This is an old slide. It was published in Annals of Oncology about 7 years ago now from Gunnar Folprecht. And what Gunnar's done is looked at all studies published in the literature of unresectable stage 4 colorectal cancer, looking at their response rate on the horizontal axis against on the vertical axis, secondary liver resection rate. And I want you to concentrate on the upper curve here, the white squares. These are patients with liver-limited disease receiving chemotherapy. And what we see is if you get a response rate of 70% or more, you would expect a liver resection rate in those patients approaching 50%. Now, is that true? We've also seen over the last 10 or 15 years, so going from the bottom left-hand corner with 5-FU flinic acid, introduction of capecitabine, then irinotecan, then oxaliplatin, that response rates have gone up significantly. So in the top part here, where we've got combinations of irinotecan or oxaliplatin, with cetuximab, Erbitux, or triplet therapy, folfoxiri or folfirinox, where we're using irinotecan, oxaliplatin, 5-FU, and flinic acid, response rates well above 50% for these patients. What we now have are 2 completely different approaches to the use of biological therapies as a result. In the upper part of this slide, we have, if you look at bevacizumab, very high progression-free survival responses, but they don't their tumours don't shrink. If you use an anti-VEGF antibody to treat patients, patients will stay alive longer, but the tumours will not shrink, nor intuitive would you expect that. If you use an anti-EGFR antibody in these patients, you don't see progression-free survival improvements, but you do see much higher response rates. So the 2 approaches are completely different in first-line chemotherapy. Again, data from Liver Met Survey. These are all patients brought to surgery by chemotherapy with or without biologicals. And what we see is the highest rate of conversion is in first-line liver limited. After that, less than 5% convert in second line, less than 1 in third line, and virtually nobody in fourth line. And what that message is that those patients you're going to convert, you've got to convert in first-line therapy. So the message is for liver-limited disease patients, throw the book at them for 3 or 4 months to try and convert them. We don't know who's going to convert, but everybody should be treated the same with the chance of conversion to resection. Here's an example of a patient referred to us in my centre, to my colleague Hassan Malik, shortly after NICE announced in 2009 that all patients with KRAS wild-type liver-limited disease should be offered chemotherapy with cetuximab. Giant liver metastasis involving left portal pedicle and half the circumference of the inferior vena cava. Patient was KRAS wild type, 6 cycles of Folfox and Erbitux, and 6 months later, this patient started 2010, much reduced, but still involving the vena cava. So using the techniques of liver transplantation, Hassan's resected the right lobe of the liver, he's taken out half the vena cava, and he's reconstructed that with bovine pericardium. We wrote that up in the Mail on Sunday as a cow saved my mum. So we can now do this kind of surgery to reconstruct the vena cava in such patients. So the way forward, this is not surgeons on their own now. We've had a paradigm shift in management. They all must be managed in the advanced colorectal cancer multidisciplinary team. This is not for the local colorectal MDT to try and address. This needs to be centralized in the liver MDT. The management must be tailorized to the individual because the management is very complicated. It involves all these treatment techniques currently, all interacting with each other. And if you take into account the patient who says yes or no to treatment, and the patient who is fit or not fit for treatment, and all the permutations of chemotherapy and biological therapy regimen, this is 2.4 million permutations of treatment strategy, which led to this. I chaired the NICE Colorectal Cancer Guideline Development Group, and we said in 2011 that if the CT scan shows metastatic disease only in the liver and the patient has no contraindication to further treatment, a specialist hepatobiliary MDT decides on further imaging to see if the patient is suitable or potentially suitable for further treatment, not the local colorectal MDT. And this is now translated over into this quality standard we produced last year and will come into contracts in England this year and next year, that people with contrast-enhanced CTs of the chest, abdomen, pelvis suggesting liver metastatic colorectal cancer have their scans reviewed by the hepatobiliary MDT, decide whether further imaging is needed to confirm suitability for surgery, and this will be in contracts with all the primary providers for colorectal cancer next year, and if you don't follow it through, you will lose money. So that's what's going to happen. So this is what we propose. You start off with liver-limited disease. Is it resectable? Are patients fit? Then let the liver team decide upon what strategy to do. If it's resectable, go down the left-hand side towards surgery. Full evaluation with patient-specific metastatic disease with PET, liver-specific Primavera MRI. Borderline resectable decided by the liver team. Test the KRAS status to see if they're eligible for Erbitux treatment or not. If they're not resectable, but they're liver-limited, still be aggressive. What do you expect? You expect surprises, okay? Things happen that you don't expect. There you are, a case like this. Multiple metastases, both low liver, 42 years of age, primary in situ, KRAS wild type, so this patient got FOLFIRI and Erbitux, did get some toxicity, but here we are, 4 months later, this disease is now resectable. Prognosis is not brilliant, but there is a chance of cure for this patient. So, and my good friend Alberto Sobrero in Genoa says, expect the accidental hepatectomy. Don't write anybody off in this situation because surprises occur. So, the strategies I'm going to propose, if you've got inoperable multiple bilobar disease, maybe 2 contiguous segments disease-free, in this case segments 1, 2, 3, test the patient with chemotherapy to start with, test the biology of the disease. I would only operate if you stabilize or respond in these patients. If your future remnant liver is small, less than 30%, do a portal vein embolization. We could spend all day discussing this. And then we do a trisegmentectomy, an extended right hepatectomy for that patient. This is the sort of situation we're looking at. Multiple metastases, really no contiguous segments disease-free. Test the disease with chemotherapy and biological therapy. Test if the patient responds or stabilizes. If the future remnant liver is small, do a portal vein embolization to increase its size. And that patient, I would do a hemihepatectomy, right hepatectomy, and ablation therapy for small metastases in the left. We call that chip and burn in my center. And that's the kind of patient we would treat. Larger metastases, more challenging case, bigger metastases, left lobe, again test them with chemotherapy, only operate if there's a response. This is the patient for a 2-stage hepatectomy where we go in at the start, clear out the future remnant liver of the left lobe. We would ligate the right portal vein so it would support right lobe with atrophy. And then 4 weeks later, we can come back in and consider a right hepatectomy to clean out the rest of the liver. And that's the kind of case we're talking about here. And that patient certainly has a chance of improved survival. Chance of cure is small, 5 to 10%, but we do Whipple's procedures if the chance of cure was 5 or 10% in pancreas cancer. Now, this is a pastime of mine. Since I had to give up golf because I got a bad neck, I thought I'd go on trekking places, and I like climbing up things, and it's Kilimanjaro at the top, and Kalapatar next to Everest, and then Annapurna Base Camp. And here I am, January 2010, top of Kilimanjaro. You can see Everest behind me in October last, top of Kalapatar, and Annapurna Base Camp with the wife last year. I couldn't do that on my own. This has to be multidisciplinary management. All of this can be only done by teams working together. And these are the teams that manage to do all of that. And if you get that result, you get happy climbers. And I can assure you from my N of 1 experiments that Kilimanjaro is as crap as Everest and as crap as Gurkha. But you need to work in teams to do this. To do that, we started 10 years ago. 3% of our patients in stage 4 are alive at 5 years. Now, I've shown you the evidence that we've now gone probably to 15% or more alive at 5 years with medical management alone. If we then throw in surgical intervention, be it resection with or without ablation, we've gone to 30% survival at 5 years for patients in stage 4 colorectal cancer, and that is 1,000% in 10 years. We've never done that before with any solid GI tumour. Now, maybe, just maybe, with what we're going to talk about in the second half of this symposium, over the next 10 years, we might get to 50% at 5 years for these patients. Thank you very much.